Okay. So I assume the questions will show up on the chat window, right?
Yeah, there'll be a chat window as well as there'll be verbal questions as well.
Okay. Okay. You see the slideshow window, right? Not the window is the proper one.
Yeah, right.
Okay. So, oops, how do I go back? Okay, so when Dr. Radhakrishna asked me to give a talk, I had this one already prepared. And my apologies if it is too specialized, but I think it also illustrates how a technique becomes standardized in a field of surgery. So I think even people who don't do liver transplants would find it interesting, hopefully. So it's about the middle hepatic vein. And the story begins in 2007. I had just finished my transplant surgery fellowship in Pittsburgh, and I had done an extra year over there. At the end of 2 years, I felt I didn't have enough liver transplant experience, so I spent an extra year doing only living donor transplants and difficult liver transplants. They had an option to spend an extra year focusing on one particular aspect of transplantation. Usually it used to be pediatric transplant or small bowel transplant, but I requested just liver transplant and they gave me that. So at that time, UPMC had the highest volume of living donor liver transplants in the US. And I was going to finish my fellowship, so I showed up to interview at Gangaram Hospital in New Delhi. And at that time, I think it was the only center in India which was doing a significant number of transplants and having good outcomes. So I had done a sort of Bharat Darshan and visited all the centers which were looking for transplant surgeons, which was not that many at that time. But I was relieved to have some sort of an offer from Gangaram Hospital. I had met Dr. Nandi in Boston, and he had more or less said, okay, come and join us. So I was very pleased with myself, very confident. I thought I was doing them a favor by joining them. And I turned up in Gangaram Hospital. Dr. Nandi took me up to the operation theater. And Dr. Swain and Dr. Subhash Gupta were sitting there. There was a transplant going on, but they were waiting in the doctor's lounge. And the first question they asked me was, what do you guys do with the middle hepatic vein? And I must admit, the question caught me completely off guard, because in 3 years of fellowship in Pittsburgh, I had not once heard the name of the middle hepatic vein. So the background of this thing is that a living donor transplant is possible because you can separate a liver into different independent parts. So there are 8 segments in the liver: 1, 2, 3, 4, 5, 6, 7, 8. And you can split the liver in such a way that you can get an independent part of the liver, which has its own blood supply, it has its own biliary drainage, it has its own venous drainage. So for an infant, for instance, you might decide to take only segment 3, or you might decide to reduce even that and take a reduced monosegment. For a small child, you might take segment 2 and 3. For a small adult, you might take segment 2, 3, 4, or 1, 2, 3, 4. Most of the time when you're doing an adult-to-adult liver transplant, you're taking the entire right lobe, so segment 5, 6, 7, 8, which typically amounts to about 60 to 70% of the liver. Now, everything else you can separate into left and right side, but there is a vein, the middle hepatic vein, which receives tributaries from both sides. So the middle hepatic vein typically has tributaries from segment 8, segment 5, as well as segment 4. So there's always been a bit of a debate about how to, which side to leave the middle hepatic vein on. So this is a 3D reconstruction of the veins of an actual liver. And typically when you divide the liver along the ischemic plane, that is when you clamp the portal vein and hepatic artery of one side, and you draw a line along the plane of ischemia, this is where it comes. So it's just along the right side of the middle hepatic vein, and you get tributaries of the middle hepatic vein coming from both sides, segment 4 as well as segment 8 as well as segment 5. And the question has always been, how do you decide what to do with this? So anyway, after it was evident that I was completely clueless about what to do with this, Dr. Soin and Subhash explained to me what had happened in Gangaram Hospital. So they had started the program with a deceased donor liver transplant program, but there were very few organ donations happening in Delhi at that time. So it soon became evident that the program could not be sustained on deceased donor transplants. There were very few donors, no designated ICU. So basically the whole team was figuring out how to do the operation like a completely new experience every time. So the outcomes were poor. Then they started the living donor program. The initial outcomes there were also poor. And they had a visit from a Turkish surgeon, Dr. Yaman Tokat. And he demonstrated how he includes the middle hepatic vein and the right lobe graft. And once they started doing that, the outcomes improved. Fortunately, they still hired me. And I spent the first 3 months of my career as a consultant assisting the fellows and learning from them how to actually do a living donor transplant. So if you look at the history of living donor liver transplantation, in the 1980s, liver transplant outcomes were improving, and it had become standard of care for liver failure. And as more and more patients were being offered liver transplant, it became evident that there were not enough donors for all the patients who need the transplant. At the same time, liver resection was becoming more common, and the mortality of the operation was dropping. So centers which were doing a large number of liver resections had mortalities of less than 1% by then. So those liver transplant surgeons who did a lot of hepatobiliary surgery had started wondering if you could take part of a liver from a living donor and use it for transplant. So the first attempt to do this was made by a Brazilian surgeon in 1988. He reported 2 pediatric living donor liver transplants. So one of them had been unsuccessful. The child had died soon after the transplant. The other child was alive at about 3 to 4 weeks after transplant, but it was evident that the graft was failing, probably because of hepatic artery thrombosis. So he reported the first 2 attempts, and I assume that child died soon after. The first successful living donor transplant was reported by Russell Strong from Brisbane in 1989. And this was a pediatric liver transplant, a left lateral segment transplant on a child from Malaysia who had come to Australia for treatment. And the mother donated a part of the liver for the child. So the early living donor transplants were in pediatric recipients using the left lobe or the left lateral segment. And after Australia, centers in the US as well as in Japan started doing living donor transplants. And it was in Japan and Korea that the next few developments in the field happened. For the first time, the right lobe was used for transplant was in 1993 in Japan. And they went in planning to use the left lobe, but they found abnormal hepatic artery anatomy, because of which they realized that they could only take out the right lobe. So this was a pediatric transplant, but it was done with the right lobe. But once they demonstrated that you can do it with the right lobe, then people started using the right lobe for adult to adult living donor liver transplant. So one of the centers which pioneered the early living donor work from adult to adult was actually where I'm working presently, which is in Richmond, Virginia Commonwealth University Hospital. And Amadeo Marcos was one of the pioneers of adult to adult living donor liver transplant. And this paper was the report of the first 40 adult to adult living donor liver transplants using the right lobe over here. So they were fairly conservative to begin with. So the question in living donor liver transplant always is how much liver volume does the recipient need? And work being done in Japan had already shown that you need at least 0.8% of the patient's body weight. So if the patient weighs 70 kilos, then you need at least 560 grams of liver. So Marcos was conservative to begin with. So in the first 15 donors, he made sure there was at least 1% body weight in terms of liver volume. And they used to biopsy every donor to assess for steatosis, for fatty liver. And the percentage of steatosis was subtracted from the estimated graft weight. So for instance, if you have a 500 gram graft and there is 10% steatosis, then they would subtract 50 grams from 500 and assume the graft volume to be 450 grams. And the middle hepatic vein always remained with the donor. So they would start the operation by doing an intra-op ultrasound and mark the plane of transaction using ultrasound rather than using clamping of the vessels. And the plane of transaction would be as avascular as possible, but on the right side of the middle hepatic vein. And the tributaries of the middle hepatic vein coming from the right side were just ligated and divided where they were encountered. So no attempt was made to reconstruct these. And they compared in this paper their first 20 cases with the next 20 cases. And they found the time required for the surgery went down from about 9 hours to about 7 hours. The hospital stay went down. They also compared the living donor transplants with deceased donor transplants done during the same time. So what they found was that the deceased donor transplants and the second half of the living donor experience was similar in terms of outcomes and graft survival and patient survival. But the hospital stay was lower in the living donor transplant recipients probably because they were transplanting patients who were not as sick as the deceased donor recipients. So they recovered earlier. But in any case, they demonstrated that adult to adult living donor transplant using the right lobe is feasible, and that after a learning curve, the results are as good with deceased donor as with deceased donor transplantation. And in this paper, they suggested that the learning curve was about 20 cases, and after that, the outcomes would improve. And in fact, that 20 case log is still what is used by UNOS when they decide whether to give permission for a center which wants to start a living donor program. The same center updated their experience later on. So this paper is from 2009 and 10-year prospective single center experience. And in fact, I presently work with some of the guys who are co-authors on this paper. So Fisher is retired, but Adrian Cottrell is still there, and he still works with me on the living donor transplants. Richard Sterling, Lukitich, and Stravitz are all hepatologists who still work with us. So over 10 years, they had done 107 cases. There was essentially no change in technique, or at least no change in the manner in which they dealt with venous outflow. And outcomes remained similar to those of deceased donor transplantation. The logic of leaving the middle hepatic vein behind for the donor was partly a concern that there should be no congestion in the remaining liver of the donor, and partly because they felt that there are connections between the veins inside the liver. And there have been studies using corrosion casts. So a corrosion cast is where you inject a resin into a blood vessel and you let it solidify, and then you use a enzyme preparation to digest the everything else. So you get a cast of the blood vessel. So this is one of the corrosion casts. And it does demonstrate some connections between tributaries of the middle hepatic vein and the right hepatic vein. They're small connections, but they do exist. And in this study, they found that in about 28% of livers, you have these small connections between tributaries of the middle and the right hepatic vein. And the theory is that over a period of a few weeks, these intrahepatic collaterals will become enlarged, and whatever congestion there is in the liver will go away. Congestion in the liver was something that centers in Korea and Japan had realized very early in their experience. And this was one of the first papers. So Sung-Gyu Lee is the head of the transplant program at Asan Medical Center in Korea. And he was one of the first to point out this problem. So they're looking at 46 living donor liver transplants between 1994 and 1998. Out of these, there were 5 right lobe grafts. And at that time, the idea was to have them draining only through the right hepatic vein. So the middle hepatic vein was not included with the right lobe, and no attempt was made to reconstruct the veins from segment 5 and 8 going into the middle hepatic vein. So in this series, the lowest graft to recipient weight ratio was 0.78. The left lobe volume, that is the remnant volume, raised from 29 to 38%. And they found severe congestion of the anterior sector in 2 of the 5 recipients after reperfusion. One of these patients died, and the other one eventually recovered, but after a very long and difficult post-operative period. And these are CT scans of those 2 patients after liver transplant. So as you can see, this is the right lobe graft, and the anterior sector of the right lobe is all congested. And this is 1 week after transplant, and this is 2 weeks after transplant. So it becomes more well-defined as time goes by. So even at 2 weeks, you don't really see any decongestion happening. So what happens in these cases is it's not that these segments of the liver are getting perfused in a normal way. What happens is that in the congested segment, you have blood going in from the hepatic artery, and then because the hepatic veins are blocked, you actually get a reverse flow in the portal vein of that segment. And then again, going out into the less congested segment. So not only is the flow reversed in the congested part, the flow is doubled in the not congested part. So actually the entire liver is getting damaged by an excessive blood flow. And that becomes a problem when the graft volume is not good. So this is a CT scan from a recent case where we deliberately decided not to include the middle hepatic vein because the predominant drainage was from the right hepatic vein. But even in here, you can see a small area of congestion, which we expect, but it illustrates that you cannot have an ideal graft if you do not pay attention to drainage of the anterior sector of the liver. So it's important to pay attention to the venous drainage of the right lobe liver graft. And the solution to this was suggested by this group of transplant surgeons from Hong Kong. And they were the first to suggest that you should include the middle hepatic vein with the right lobe, which is transplanted. And so their criteria were that the graft weight should be more than 40% of the estimated standard liver volume. So there are formulas to estimate the standard liver volume based on the patient's sex and age and weight. So 40% of standard liver volume corresponds approximately to a graft recipient weight ratio of about 0.8%. They're not changing that part of the equation. And they wanted a left lobe, a remnant liver volume of more than 30%. Now, unlike the American technique, the Hong Kong guys used to decide the plane of transaction by clamping the right portal vein in the hepatic artery. So when you do that, you see the right side of the liver turn dusky, and you can mark on the surface of the liver where you're going to do the transaction. When they did not see a clear plane, they would use ultrasound to locate the middle hepatic vein. So they would follow the middle hepatic vein all the way to the vena cava, or if it's joining the left hepatic vein, they would follow it all the way over there. And if you had a big vein from segment 4 joining right at the top, then they would stop just short of that. So they would leave that intact on the donor side, and the rest of the middle hepatic vein would come out with the graft. And they were doing Doppler studies to assess the flow on the left side as well as later on the right side. And as their outcomes improved and they had less and less complications, they stopped putting drains in the donors. So they had a series of 93 right hepatectomies. And in some of them, they went down to as low as 23.6% remnant volume. In fact, almost 20% of their donors had a left lobe volume of less than 30%. Most centers would not accept donors like that nowadays, but they decided on the basis of the age of the donor and the medical indication for the transplant and so on. So the middle hepatic vein drained directly into the vena cava in 41%. In 15%, it was larger than the right hepatic vein, and in 43%, it was the same size as the right hepatic vein. So basically, the message is that it's important and you can't ignore it when you do a living donor liver transplant. So they took the middle hepatic vein in almost all the cases. In just one patient, they left it behind, one donor, because of some abnormal anatomy. In 48% of the donors, they were able to preserve a sizable segment 4 vein draining into the top of the middle hepatic vein. And they did Dopplers at the end of the operation, and they were looking at venous supply and drainage of the donor side, the segment 4. And they found normal direction of flow in 60%, stagnant flow in 21%, and some reversal of flow in the rest of them. So this is what other centers point at when they worry about taking the middle hepatic vein with the graft, that you have congestion on the donor side, and you don't want that happening, that it may be safer for the donor not to do this. In any case, duration of donor surgery was nearly 9 hours. Median blood loss was just under half a liter. Hospital stay was 10 days. There was no donor mortality in this series. 26% complication rate, which is not particularly high. Most of the complications are mild complications. 4 donors with a high bilirubin, and these were associated with fatty livers. So they were not doing routine biopsies in all donors. So sometimes they would operate and find that the liver is more fatty than they expected. And these were the donors who had slower recovery. And they found no difference in liver function between donors with remnant more or less than 30%. So even in their 20% of cases where the remnant volume was less than 30%, the donors did fine. So like I said, in about half the cases, they were able to preserve a segment 4 vein in the donor, and in half they were not. And the INR was slightly higher on the first post-op day in the donors in whom all the segment 4 veins were sacrificed. But after that, there was no difference. So it made a transient difference which didn't last for long. And if you look at recipient outcomes, 9 of the recipients had, so one of the recipients obviously had a graft which did not have the middle hepatic vein, and 8 of them had obstruction of the middle hepatic vein, which was taken with the graft. So of these 9 patients, 2 died of liver failure, 1 died of an invasive fungal infection. 6 survived, but those 6 had a slow recovery with a prolonged cholestasis. But all the recipients who got grafts with patent middle hepatic veins had a good outcome. Well, most of them had a good outcome, 94% overall survival, and no mortality from liver failure. So the sepsis issue remains, but the small for size graft issue seems to go away if you include the middle hepatic vein with the graft. They also felt that the donor segment 4 is better able to tolerate venous congestion than the recipient anterior sector, because unlike the graft that you're taking out, on the donor side, there is no ischemia, reperfusion, and there's no portal hypertension. Whereas on the recipient side, the graft is going through a period of ischemia and reperfusion, and also the portal vein that is being connected to the graft has a very high flow. So both those things mean that the graft needs a good venous drainage more than the remnant does. So this is what a right lobe graft looks like when you take it without the middle hepatic vein. There's a zone of obvious congestion. So this is when you put the graft in, you've connected the portal vein, connected the hepatic vein, and unclamped. So this is what it looks like after reperfusion. And then when you connect the hepatic artery and open it, the congestion clears up. But as they pointed out, it's not clearing up because you've got normal flow into this part of the liver. What's happening is that blood is going in through the hepatic artery, and it's coming in reverse. So the hepatic veins are not draining this part. So it's coming out in reverse through the anterior portal vein and then going into the posterior sector. So you have abnormal flow in the anterior sector and an excessive flow in the posterior sector. So it affects the whole of the graft. And that can be a problem unless you have a big margin in terms of size. And they updated their experience when they got to 200 cases. And they found that their learning curve began to plateau after about 50 cases. So after that, their operative time came down, and their outcomes began to standardize. So again, there was only that one donor in whom the right lobe graft was removed without the middle hepatic vein. All the others had the graft with the middle hepatic vein. And I'm always amazed when I see the BMI figures for the Japanese and Korean and Hong Kong transplant centers. So the median BMI of these donors was 20.9. So it's really easy when you get an occasional donor who's got a BMI like that. Most of our donors have BMIs in the early 30s. So the median hospital stay came down from 10 days to 6.5 days. And one donor was admitted almost 3 months after donation with an upper GI bleed. So she was taken to endoscopy and she collapsed and died during the upper GI endoscopy. And on autopsy, they found duodenocable fistula. It looks like she must have been taking a lot of NSAIDs, non-steroidal anti-inflammatory drugs, and that caused a duodenal ulcer which eroded into the vena cava. And she probably died of air embolism during the endoscopy. So this is an autopsy photograph of the duodenum showing the ulcer which had eroded into the vena cava. So a rare complication, obviously not related to surgical technique. So it does not seem to matter to the donor whether you include the middle hepatic vein in the graft or not. So we're not killing the donors by taking the middle hepatic vein, but maybe we are hurting them. So would they have an easier recovery if we did not? And most of the centers which don't like to take the middle vein with the right lobe think that the donors recover easier if we don't include the middle hepatic vein. So again, data from the same center from Hong Kong, and they're looking at remnant liver size and recovery. So does it matter in terms of how quickly the patients recover? So when we operate on patients for liver cancer, we accept leaving behind as little as 25% of the liver. And in pediatric cases, even 20% is acceptable. But for liver donors, most centers want an additional margin of safety and generally use a lower limit of 30%. So this is a series of donors in whom the transaction was done on the left of the middle hepatic vein. So the middle hepatic vein was included with the graft. And they looked at graft volume as more than 35% of standard liver volume of the recipients. So this corresponds to about graft recipient weight ratio of about 0.7%. So by then they had reached 349 right lobe liver donors, median body weight 57. Every time I see that, I envy their surgeons. Median hospital stay 6 days. 81 of the donors had a remnant volume of less than 30%. So these donors had a peak bilirubin of about 4, a peak prothrombin time of about 18.8 seconds. Again, the one mortality in their series was the one duodenocable fistula. One donor met criteria for liver failure, and this was one who had a remnant volume of more than 35%. So this seems to be a donor in whom they found an unexpectedly fatty liver early in their experience. So, and if you look at their values, this is bilirubin, and it goes up higher if you have a remnant volume of less than 30%, but it comes down by about 1 week. It's this, everything, all the parameters are the same. So maybe these guys in Hong Kong are just great surgeons working on thin patients. So what about centers which do this routinely? Should they switch? Does it matter for the recipient? So we move over to Japan, and this is data from Kyoto, which is one of the pioneering living donor transplant centers there. So they started doing living donor transplants in 1990. And in about 2000, once they saw the data coming out from Hong Kong, they started including the middle hepatic vein with the right lobe graft, at least in selected cases. So in their series, they have 40 cases in whom the right lobe graft was included out of 217 total right lobes. So their criteria was that if the graft size was less than 1% of the recipient weight and the remnant volume was more than 35%, then they would include the middle hepatic vein with the graft. And again, their donor population is similar to what they see in Hong Kong. So thin patients, weight of 58 kilos. And what they found was comparing these patients with and without the middle hepatic vein. So this is their technique. So they would do one anastomosis with the right hepatic vein, and they would join the middle hepatic vein to a common cuff of the left and middle vein when they implant the graft. And they found that the graft survival in the recipients when they had graft with the middle hepatic vein was 86%, whereas without middle hepatic vein it was 74.8%. So the outcomes for the recipients are definitely better if they get a right lobe with the middle hepatic vein. And gradually we started seeing data from other centers, and other Japanese centers started doing the same thing. So this is data from another Japanese center, 253 right lobes. Fairly conservative in terms of how much volume they want for the recipient. 30% at least remnant volume, which is standard. And they considered including the middle hepatic vein when the donor was less than 50 years old and the remnant volume was more than 35%. So all the Japanese centers are trying to be more conservative than the Hong Kong guys. And when they did not take the middle hepatic vein, they calculated congestion volumes of the tributaries from segment 5 and 8. And they reconstructed these veins if the subtracted volume was not sufficient. And they used cryopreserved veins for the extension grafts. So most centers which do living donor transplants now have access to software like this, which can analyze data from CT scans and calculate for each vein how much of the liver volume is going to get congested. So they were using this data to decide whether to reconstruct these tributaries of the vein or not. So 253 right lobes. In 47 of them, the middle hepatic vein was included. In 114, the middle hepatic vein was not included, but they reconstructed the tributaries from segment 5 and 8. And in 92 of them, the middle hepatic vein was not included and the tributaries were also not reconstructed. So in the third group, the graft to standard liver volume ratio is 53%. So these were really large grafts, and they thought they could get away with not doing an optimal venous drainage. And they were generally conservative. So even in the first group, they have fairly large graft volumes. What they found was that in the third group, when they were looking at regeneration of the graft, the anterior sector was not regenerating well. And even if you look at regeneration of the whole graft, it's better in the first group when the middle hepatic vein is included with the graft. And in the first group, when the whole of the middle hepatic vein was included, they never had any thrombosis of the vein. In the second group, when they were trying to reconstruct the tributaries of the middle vein, they had occlusion rates of 45%. And in this group, group 2, when the veins thrombosed, they behaved basically like the third group, where the veins were not reconstructed at all. Similarly, centers in Taiwan followed suit. They followed the same procedure. So they describe outcomes in 200 donors, 202 right lobes. In 200 of them, the middle hepatic vein was included. So they were basically following the Hong Kong technique. And they had similar outcomes: no donor deaths, peak INR 1.3, peak bilirubin 8.6. So it's possible to take the middle hepatic vein with the graft in all cases and have good outcomes. But we're still looking at thin oriental patients. What about big Western patients? So we come further west, to an extent at least, we come to Turkey. And Turkey has several large volume liver transplant centers, and they've been doing quite innovative work in living donor liver transplantation. So they're describing outcomes in 240 adult recipients of right lobe liver transplants. And they're leaving the middle, so this particular center was leaving the middle hepatic vein behind in the donor and reconstructing anterior sector veins which are more than 5 millimeters in diameter, if the graft size is marginal, less than 0.8% of body weight. And they were using PTFE grafts for reconstruction. So in patients, in recipients in whom the anterior sector drainage was not reconstructed, there were many more complications. The complication rate was 78% compared to 21%. They had more bile leaks, 73% versus 27%. And they even had a higher rate of acute rejection, 85% versus 14%. So rejection is probably because if they have a bile leak and infection, they have to reduce immunosuppression and then they get an episode of rejection. But even so, the results are much better when the venous drainage of the anterior sector is reconstructed than when it is not. Moving further west, this is data from France. And here also they realized that eventually that you have to include the middle vein with the right lobe. So they recognized it's a more technically challenging operation, may cause venous congestion of segment 4. So they were doing it similar to what was described in Hong Kong. They would do the transection along the left side of the middle hepatic vein. So in the early part of their experience, they used to take all right hepatectomies without the middle hepatic vein and without reconstruction of the tributaries. And in the second half of their experience, it was included in the graft in all cases. So 20 in the first half, 21 in the second half. They found no difference in donor morbidity, no difference in donor hospital stay, no difference in bilirubin or liver enzymes. So the prothrombin time was slightly higher on day 1 and 3, but otherwise no difference really in recovery of the donor. No difference in regeneration of the remnant liver. And so they found that whether you take the middle hepatic vein or not, it does not increase the risk for the donor, but it does change the recipient for the outcome. So more and more centers began learning how to do this. And so it was an Essen in Germany as well, where they had 83 adult-to-adult living donor transplants, 71 of them with the right graft. And in 59 of these 71, they included the middle hepatic vein. And out of the 12 in whom they didn't include it, they reconstructed it in 4 of them. So more and more, the default option was becoming taking the right lobe with the middle hepatic vein. So we're not hurting the donors, but we are not really comparing the two groups at the same hospital, right? Because the MHV group is later on in the learning curve of most centers. So we're not doing them at the same time in the same place. So we come to the University of Toronto experience in Canada. This is one of the largest living donor liver transplant centers in the West. And there also it followed the same evolution. So in the first part of their experience, they would routinely ligate the tributaries of the middle hepatic vein. In the second part, they would reconstruct the tributaries. And in the third part, they would include the middle hepatic vein with the grafts. So this was 56 right lobes, which was 20% of their adult liver transplants over that period. They also did not routinely put a drain in the donors. So they have 28 patients with right lobe without middle hepatic vein and 28 with middle hepatic vein. So exactly half and half. The duration of surgery was shorter in the second group with middle hepatic vein, which is probably because it's later in their learning curve. And the blood loss was also less in that group. Peak bilirubin was similar. Time to normal bilirubin was similar. Peak INR was higher when the middle hepatic vein was taken with the graft, but there was no difference in time to normalization of INR, no difference in donor complications, no difference in hospital stay, no mortality in this series. And if you look at recipient outcomes, when the recipients got a right lobe with the middle hepatic vein, the 1-year graft survival was 95%, and without it, it was 81%. And 2 of the recipients who got grafts without the middle hepatic vein died of small foci syndrome, even though their graft size was adequate. So it doesn't hurt the donors. It's definitely better for the recipients, but it's not randomized, right? The grafts with middle hepatic vein are later in the learning curve of the center. So the only way to tell whether it makes a difference to the donors is to get to do a randomized control trial. I thought it's impossible to do a randomized control trial of something like this. And I was very impressed to see this paper from Amrita Institute in Kochi, where they've actually done a randomized trial on extended versus modified right lobe grafts in living donor liver transplants. This is published in Liver Transplantation, I believe. So they selected donors in whom it was okay to do both. You could either include the middle hepatic vein with the graft or leave it behind. And they excluded patients with ABO incompatible transplants, portal vein thrombosis, small graft weights, so that it would be a fair comparison. So they randomized 86 patients, 43 in each arm. And when they included the middle hepatic vein with the graft, it was patent in 91%. And in cases where the vein was left behind and tributaries were reconstructed, it was 81%. And they found no difference in donors in liver function tests, hospital stay, complications. So they basically established that it doesn't matter to the donor recovery whether you include the middle hepatic vein with the graft or not. So no difference to the donors, and it lets us get away with putting small grafts into big recipients. But these are short-term results. So what happens in the long term? So maybe these donors don't do as well in the long term. So again, we look at long-term data from Hong Kong. And what they found was that regardless of the initial graft weight, once liver regeneration happens, the long-term outcomes are not different. So the long-term graft survival rates are the same for recipients who got small grafts as for those who got large grafts. You basically have to get them past the first 2 weeks, and after that, they do equally well. So the Hong Kong guys seem to have sealed up the question every way, but what are the Koreans up to meanwhile? So we come back to the Asan Medical Center, which is the largest living donor liver transplant center in the world. And they were the ones who first pointed out the problem of anterior sector congestion. And they started reconstructing the tributaries of the middle hepatic vein in 1998. So they took some extended right lobe grafts, as they called it, which are right lobes with the middle hepatic vein. And even in the ones in whom they did not take the middle hepatic vein, they recognized that its drainage is important, and they reconstructed the tributaries. And they would often use PTFE grafts for these. So this was how they did the operation. So the right lobe is taken without the middle hepatic vein, and a graft is used to reconstruct the tributaries. But sometimes, so they have excellent outcomes. They have like a 95% 1-year survival of their recipients. But sometimes the best place to look for a surgeon's complication is in the papers published by the radiologist from the same center. So this is Doppler ultrasound follow-up of these grafts from Asan Medical Center, and 240 living donor liver transplants in which the middle hepatic vein was not included, but the tributaries were reconstructed. So a total of 564 middle hepatic vein tributaries were reconstructed. And they're looking at Doppler ultrasound to measure the flow and patency of these veins. And they were comparing it with CT scans when they had a CT scan, which was done around the same time as the Doppler. And you can see the patency rate of these vein grafts drops, and about 18 months after transplant, most of them have thrombosed. So this is not an ideal technique. This is one of the images they included in the paper. You see a thrombosed tributary of the middle hepatic vein on Doppler. And on CT scan, you see this thrombosed vein and congestion of the anterior sector of the liver. So some of the complications even show up on endoscopy. And you see a case where the PTFE graft has eroded into the duodenum. And obviously you can't leave it like this, because the concern is that someday it will get eroded and it will bleed. So they had to go in and perform a massive operation with a partial gastrectomy and remove the graft and so on. So it's serious complications can happen. But these are high volume expert centers. So you really need a meta-analysis to see what happens from data from all the centers which are doing this and publishing data. So this is a meta-analysis which a group of Chinese surgeons did. And they looked at several studies in which they've compared donors with and without middle hepatic vein. And they found that there was no difference in donors' liver functions, no difference in donor complications, but the recipient liver functions better when they get grafts, including the middle hepatic vein. So what do we do? This is our protocol, which started in Gangaram Hospital and then later Kokilaben Hospital and now over here. So there are three types of right lobe grafts. Standard right lobe, where the anterior sector veins are not reconstructed at all. The extended right lobe, which is like the Hong Kong protocol, where the middle hepatic vein is included in the graft. And modified right lobe, where part of the middle hepatic vein is included in the graft and tributaries are reconstructed. So this was between Gangaram and Medanta, 693 living donor liver transplants. 596 of them were adult to adult right lobe. So the policy of including the middle hepatic vein with the graft started in 2006. So we're looking at 358 transplants over a period of 4 years, who had, at the time when we were looking at the data, at least 12 months of follow-up. So if you look at this kind of anatomy in the donor, so you have a large segment 4 tributary which is draining into the left hepatic vein. So in this case, it's okay to include the middle hepatic vein with the right lobe. But you also have this large segment 8 vein which is joining right on top. So you don't want to go right up to here and take a common cuff, because there's a risk of narrowing the left hepatic vein. You stay a little further away and take both these veins separately. So you're going to get a right lobe graft which will have a right hepatic vein, a segment 8 vein, and a middle hepatic vein. And then you have to reconstruct this during implantation. But this will be a perfect graft with no congestion, and a perfect remnant also with no congestion. This is good anatomy. This is the best kind of anatomy for us, where you practically have a double middle hepatic vein. So the segment 4 is draining into right on top where the middle and the left hepatic vein are joining. So you can basically include the middle hepatic vein with the right lobe graft, and you don't have any large tributaries joining on top. So you have a single vein to reconstruct. This is the easiest kind of right lobe graft to take. This is more difficult, where you have major segment 4 veins draining into the middle hepatic vein. So what we would do is go along here, leave this side intact. So basically leave most of the middle hepatic vein behind. So we have to reconstruct 2 veins, this large segment 8 vein and this part of the middle hepatic vein. So these are the 3 basic type of grafts. And we found that the ischemic plane generally takes you to the right border of the middle hepatic vein. So we don't move the plane to the left of the middle hepatic vein the way the Hong Kong group had described. We stay in the ischemic plane and we core the middle hepatic vein out of the left side. So this is what it looks like when the liver is being split. That's the middle hepatic vein, that's a vessel loop passed around it. This is another photograph from a different angle. So basically, you have the middle hepatic vein on the surface of the graft, kind of bulging out of the surface of the graft, poured out of the other side. And we make sure there's a good stump over here, that we're not getting close to the left hepatic vein, that there's no risk of narrowing the left hepatic vein. And depending on the length of the middle hepatic vein we have with the graft, there are different ways of reconstructing it. So this, you directly connect it to the IVC. This is rare. You can rarely do that. You normally have some shortage of length. So this is the most common way. You need a short extension graft to connect it directly to the vena cava. Then you may have two separate veins, but they are close enough that you can do a venoplasty and just put a short straight vein graft. Or they may be too far apart to do a venoplasty, so you need a Y graft over here. Or it's even further, and you have three separate veins. You can venoplasty two of them together, and you put a Y graft over there. So with these various methods, you can generally reconstruct all right lobe grafts. So this is one, you saw the CT scan earlier, so this was from this one. You have a middle hepatic vein, you have a right segment 8 vein. So this is how we reconstruct it. You do a venoplasty between the segment 8 vein and the middle hepatic vein. These are the sutures where the two veins have been joined side to side. And we put a short extension graft onto them. This is one where a Y graft was required, so you put an extension Y graft. And this is what the liver looks like after reimplantation. So you saw what the liver looks like when you don't include the middle hepatic vein. There's a big zone of congestion here. But in this case, it's completely normal. There's no congestion at all. So this is what a liver graft looks like when you include the middle hepatic vein with the graft. So in those 358 cases, 60 of them had part of the middle hepatic vein included with the graft. And in 298 of them, it was mostly included with the graft, subtotal middle hepatic vein. So there was no liver failure in any donor. There was one donor mortality, which was a young donor who had an uneventful hepatectomy, good size remnant, extubated, moved to the ICU, and for some reason went into status epilepticus and developed hypoxic brain injury. So died of neurological causes 11 days after surgery with normal liver and kidney function. One donor had prolonged ascites and cholestasis and had a high gradient across the left hepatic vein, which we thought was positional. Maybe the liver wasn't fixed well in its position. Maybe it was moving over to one side because of regeneration. Anyway, this resolved after stenting of the vein. In the recipients, a very low incidence of venous complications, 0.5%. Two patients basically had thrombosis of the veins. In one of them, it could be stented and the patient could be salvaged. The other one died of liver failure. So overall, patient survival at follow-up of 798 days was 88%, which is fairly good. So to summarize, the middle hepatic vein can be included with the right lobe in all cases without any adverse consequences to the donor. If you want to follow a more selective approach, then you can take various lengths of the middle hepatic vein depending on the venous drainage of segment 4. And you can use this tailored approach based on how much the graft recipient weight ratio is, how much the remnant liver volume is, the anatomy of the venous drainage, the severity of portal hypertension in the recipient, the metabolic demand of the recipient, the volume of segment 4 in relation to the volume of segment 2 and 3. So basically, if you want, you can always include the middle hepatic vein with the right lobe graft. That's an acceptable policy. Never including it is not an acceptable policy. So you have to pay attention to drainage of the anterior sector of the right lobe to do this operation well. So thinking about the middle hepatic vein improves the outcomes of living donor liver transplantation. Not thinking about it means you have suboptimal outcomes. We can take questions now.
Yeah, thanks, Vinay, for a wonderful, crisp, comprehensive lecture on a very focused topic. And I shall open the floor discussion. Any questions from the audience?
Hello, can you hear me, sir?
Yeah, I can hear you.
Hey, this is Mahesh. I'm a transplant surgeon from Coimbatore in Tamil Nadu.
Okay.
I trained in Cleveland, and
Sorry, your sound seems to have stopped.
Yeah.
We couldn't hear
Mahesh,
you.
friend, carry on.
hello.
Yeah.
Sorry, sir. The internet got a bit of interruption. So in Cleveland, we always leave the middle hepatic vein with the donor, and we always reconstruct the middle hepatic vein with the cadaveric grafts. And you rightly mentioned the middle hepatic vein, the new middle hepatic vein that we reconstruct over a period of time slowly get thrombosed over a period of like year and a half. But by the time they may have the venous drainage, might have developed some collaterals with the right hepatic vein, so it may not affect the graft function. That's what they have been told. But this is like I've read a lot of papers about it, but I was very reluctant to include the middle hepatic vein and the right lobe. Left lobe we have taken multiple times, but right lobe.
Left lobe, you always take the middle hepatic vein with the graft. There's no point in leaving it behind when you're taking a left lobe graft.
Correct.
So it probably doesn't matter if you have a good graft recipient weight ratio, but if you have a small graft, then you want optimal drainage. Now, when you reconstruct the tributaries, you're reconstructing maybe 2 tributaries, one from segment 5, one from segment 8, which are more than 5 millimeters.
Yes, sir.
But there are many smaller tributaries also which drain into the middle hepatic vein, which you can't reconstruct.
Okay.
So even if you reconstruct 2 large 5 and 8 veins, you still have some amount of congestion in the graft.
Okay.
So it may not matter if your GRWR is 1% or 0.8%, but it will matter if you're putting in a graft with a GRWR of 0.6%, for instance. You want perfect drainage. And the concern.
The other thing that we always do is like.
Yeah.
Another thing that we always do is, always.
We couldn't hear you.
The portal flow is quite high in the recipient. That is the reason that you think the graft suffers. So we routinely do splenectomy. So we reduce the portal flow in the living donor transplants. So we modulate the portal flow. That may be another reason I'm thinking. That's why we don't get much of the congestion from the much of the congestion as well as the graft function reduction or anything in the post-transplant period. I don't know, because this is my limited experience from Cleveland Clinic over there. But here, we are a little bit afraid of including the middle hepatic vein and the right lobe. That's the only thing that
that's why I presented the data. The data shows that it makes no difference to the donor whether you include the right lobe or not. There's no difference in morbidity, mortality, nothing changes. Even the liver failure rate, which anyway is very rare in liver donors, it doesn't seem to happen. So the concern that you're hurting the donor by taking the middle hepatic vein seems to be unfounded. It does not seem to matter to the donor.
One final question, sir. When do you consider not to include the middle hepatic vein in the right lobe? For example, if the donor's FLR is 30, very close to 30, if you take the middle hepatic vein, sometimes you may give congestion to the remnant liver, then that may, adversely affect the donor. So is there any cutoff do you have? Like with this criteria, I would take.
So if you're not following a protocol of always including it, then the things you look at are in the donor, how much of the remnant volume is segment 4, how much is segment 2, 3. So some donors, you have large left lateral segment and a very thin segment 4. And there you're not worried about congestion of segment 4 because it's not much of the remnant. You're also looking at what the graft recipient weight ratio is for the recipient. So if the recipient is getting a graft which is say 1.2%, then you don't mind if half of it is congested.
Okay.
So all these things go into making the decision.
Okay. Thank you.
And you're right. Ligating the splenic artery or doing a splenectomy is a way to reduce the portal flow. And the injury to the graft is a combination of congestion and excessive flow. So you can help prevent the injury by reducing flow as well.
Sure. Thank you.
Vimal, you have any comments? Vimal, are you there? Ilango? Any more queries or comments to Vinay?
Can I ask one more question?
Yeah.
Yeah, sure.
So, will congestion, does it affect any way obviously when there is a congestion over a period of time, that lobe becomes atrophic, and then does it cause any biliary complication? Because usually the classical teaching and classical belief is the biliary tree is supplied by the artery rather than by the portal vein, or even blocking the vein will not affect the biliary system. Then why these patients do develop some biliary strictures?
Yeah, that's interesting because several studies have shown that if you don't have a perfect graft, if you have a congested anterior sector, there's a higher incidence of biliary complications. I agree, the biliary system is supplied by the arterial system, but it may be that if the venous drainage is compromised, or if you have like small thrombi forming on the venous side of it, you get a congested bile ducts. And these either may become ischemic and scar more, or they may compromise the manner in which you're doing the reconstruction. So certainly it seems like the venous drainage does seem to affect the rate of biliary complications. I don't have a very scientific explanation for this, but my guess is it's related to edema rather than anything else.
Okay, sir. Thank you.
Vinay, there are a couple of questions from the Facebook group. There's a group following in the Facebook as well. Dr. Dinesh wants to know, can cadaveric graft act as a source of infection? How do you preserve them?
There's no reason why a cadaveric graft should be a source of infection if you're careful about the serologies. Obviously, you don't want to put a cadaver graft from a donor who has Hep B or Hep C into a living donor graft. But as long as you're careful about the serologies, it should be okay. So we only cryopreserve grafts from serology negative cadavers, and only those are used. If you're worried about bacterial contamination, unless there is a breach of asepsis, that should not happen.
How do you preserve the grafts is what this question was.
So what we do here in the US is just 14 days in the regular fridge. So for up to 14 days, you can use it if you don't freeze it, as long as you keep it at 4 degrees. What we were doing in India was we were freezing it in HTK solution and keeping it at -40. And we were using it for up to 6 months.
Vimal, you have any questions? Vinay, if you open the chat box, there are a question or two, if you can address them.
Sorry, I have. Is this? Where do I find the chat box?
Okay, I'll read them out for you.
Okay, yeah.
I mean,
yeah,
a question unrelated. It says, what is your experience of liver transplant in colorectal liver mets?
So we are just writing a protocol to start doing it. We haven't done any yet. We want to do it. Now in the US, there are no MELD exception points for colorectal liver mets. So the chances are that we will have to do this only in patients who have living donors. So that is our plan, that we're going to define criteria to select patients who are relatively low risk for recurrence and offer them living donor liver transplant and see how this happens, how this works. The best data we have is from Oslo, where they've done more than 40 such transplants. And they have found that although almost everyone recurs at some point, the 5-year survival is not bad. they have something like a 60% 5-year survival in these cases. And what they have found is that you get these slow-growing indolent recurrences in the lung, which can often be resected. So you do a transplant, you get rid of the disease in the abdomen, you get a small recurrence in the lung, you operate again, you take that out again, and you can get a reasonable long-term survival with that. So it's definitely something worth looking at, and we are one of the centers working out a protocol to start doing that.
Can I share the information from Cleveland Clinic regarding this, sir?
Yeah, sure.
So we have done the first living donor liver transplant for colorectal liver met in the US, and the protocol that we do use is like we have to make sure we exclude all the extrahepatic disease, and the patient should be stable on chemotherapy for at least 6 months. Then we do like every 3 months CT scans, and then if there is no progression of the disease, then we accept them for liver transplant. But definitely at the time when I was there as a fellow, we don't have approved by the OPTN or the UNOS for the cadaveric organ. So we did the first transplant, and I followed the patient almost like 6 months to a year, and we didn't see any recurrence on the patient. So that's the experience that we do have, but we have got a clear protocol for colorectal liver mets over there.
Yeah, it's something promising that we need to look at, but I agree, the experience is small so far.
So thanks, Vinay, for an excellent lecture. I should say the audio and video is excellent, and maybe the strength of your Wi-Fi, I do not know, but we'll be very glad if you come on our screens more often.
Sure.
Don't give a monthly date, that's too far.
That's just a compliment from our side. Like your lecture was so like it's focused, but you told us a story rather than like it's a lecture. So it's like from the east to west, it's moving. It's like we know what other centers are doing, and the way that you explain also, it's very, very impressive, and it's actually encouraging for us to do these type of cases. So thank you so much for this.
Thank you. I was a little worried that it's too specialized for most of the audience, but I'm glad that those of you who are interested in this liked it.
You should come on this platform more often, Vinay, and because with your experience of writing a book, I'm sure you'll have a lot of visuals and all that. I will be very glad if you do at least a lecture or two a week.
Oh my God, a week, maybe a month.
A month is too long. Anyway, thank you so much. Thanks for your time.
Thank you for inviting me.
See you again soon. Bye.
See you.